I wish I could do a Dick Michaud sort of impression. I got his attention. Because he would say something like, this is all great, but we need more. Ginny, he seems very demanding. And so our next speaker, I think, is along these lines. What you've heard about so far is, largely the past, the present, but what about the future? And that's a lot about what, NPKU is about, is looking to the future. And what can we do even better? And trying to find, push this all the way to sort of the cure level. And so the last speaker of this session is Ira Fox, who will be talking about transplantation of isolated liver cells and where the future for PKU is at. Ira?
Well, this is actually a terrific experience for me. Actually, it's probably more of an educational experience for me than it may turn out to be for you folks. I actually come to this so looking to learn from you folks as to whether transplantation has a role at all in the treatment of fetal ketonuria. In fact, before I moved to Pittsburgh, I actually never considered this as an option, and then I've run into some families and some of my colleagues who convinced me that, in fact, there may be a role. And I think what I'm hoping to get from this group is an understanding of whether any aspect of transplantation would actually, whether the risks would be worth it for the benefits that we can provide. So the first thing, the reason for the title is actually it doesn't have PKU in it is because really most of the work I've done in transplantation is related to diseases of the liver that are associated with high mortality. I was an organ transplant surgeon for many, many years. Actually, was a transplant fellow with Dr. Starzl in 1983 when he first moved to Pittsburgh. But I always had a research component in me where I was interested in finding alternatives. And for a scientist, we all know we're trying to put ourselves out of business. So I sort of started, just by happenstance, getting into the business of transplanting liver cells instead of transplanting whole organs because for many of the same reasons that people got into gene therapy, and that is, well, why are we replacing an entire organ when really the problem is that we've got an enzyme deficiency? But being a liver transplant surgeon, the only population I usually thought about were the patients who were going to die if they didn't get a liver transplant who had enzyme deficiencies. And those are the Crigler-Najjar patients, the urea cycle disorders, and a lot of other diseases that don't include PKU. And, because you only get a limited exposure once you get sort of specialized in certain diseases, I always thought of the PKU community as sort of a stable community, sort of had your therapies, and transplantation was a high-risk issue. So the first thing I think that I'd like to do is to educate you folks actually a little about transplantation. The slides that I'm going to have up here related to PKU are mostly for my education, not for your education, just to give you some idea for the misunderstandings on both ends of the aisle here, so that we can sort of come together and maybe at the end of this come to an appreciation of whether transplantation can play a role. So this is what my view of your perspective on organ transplantation, and this is my view below of my perspective on PKU, and that is that most people who don't have a relative or someone who needed a transplant view transplantation as extremely risky, expensive, and experimental, and that the quality of life after a transplant is really quite marginal and maybe gotten a little bit better recently, but it's still not great. From my perspective, what my colleagues tell me is what you all know about PKU, and that is most folks don't tolerate their diets very well. Levels of Phe are potentially problematic. And again, I think what I'm offering and what I'm talking about with transplantation doesn't necessarily apply to everybody with PKU. There's some patients who are very well controlled on diet. There's some folks who get very well controlled on the addition of the cofactor. And so what I'm really talking about is patients who might be in the extremists of this disease whom this might apply to. In fact, I don't really want to talk about the other issues on PKU because you folks have just heard about them and know more about them than I do. So I'm going to focus on the issues related to transplantation just to educate you that maybe transplantation, even organ transplantation, is not the scary thing you think it is, and then we'll move into the issue of cell transplantation. So the first and most important thing is that liver transplantation is not what you remember it to be when it first started becoming successful in the early 1980s, where we used to use tremendous amounts of blood. That survival at the first year, if we were lucky, was on the order of 7 out of 10 patients. That at 5 years, we're lucky that half of our patients were alive. And that's really what the state of the art was at the time. And that was with the brand new immunosuppressive drugs that we were using, mostly cyclosporin at the time. Well, in fact, now the field of organ transplantation is dramatically improved. This is actually the data from our program at the University of Pittsburgh, and this is the Children's Hospital. This is data from the Children's Hospital. And you can see here, this is more than 10-year survival on the order of 90%. Now, to a patient with PKU, 90% survival may not be so great, but we're really talking, again, we're talking about patients in the extremis. We're talking about patients who are in the intensive care unit on ventilators. Now, not all of the patients are in this extreme state, but of those 10% of patients who die after transplantation at 10 years, that's where the vast majority of those patients come from. These are children with acute liver failure who are on ventilators, have intracranial pressure monitors coming out of their heads, and have, at best, a 70% or 60% survival even after transplantation. We're talking about children who have tumors of their livers, who also don't necessarily have long-term survival because the disease may recur after transplantation. So the message I want to give you is that, number one, patients who have organ transplants do well. Now, I'm not trying to convince any of you to have an organ transplant. Don't get the wrong idea. I'm just trying to I'm trying to set the table that the complications associated with transplantation, the long-term survival, even after organ transplantation, really is not so bad, and that the side effects of the immunosuppression drugs and the lifestyle of patients who have organ transplants are not so bad. Or I wouldn't have been doing it for this long. So the other piece of information that's very important for you to understand is not only what the survival is, but how people do afterwards. And so this is a multi-center trial. It's probably the best way to get a handle on what the real side effects of the drugs are and the survival, the complications besides issues of mortality really affect these folks. And I think one of the most important messages here, again, here's the mix of patients who have these transplants. So only 13% of this entire population of 461 kids who were followed in this 4-year follow-up, only 13% of these kids have liver-based metabolic disorders. Now, again, just because you have a liver-based metabolic disorder doesn't necessarily mean you're going to go to the operating room in terrific shape. There are many children who are newborns who have urea cycle disorders, have hyperammonemia, and are at very high risk for having neurologic disorders to begin with. But the vast majority of the patients have biliary atresia. Those folks actually do fairly well, but there's a subpopulation of those patients who also don't do very well and come to transplantation with huge amounts of fluid in their abdomen, having nutritional depletion. They look like those pictures, for those of you who are old enough to remember those children in Biafra who were protein depleted, who had basically no muscle mass, giant bellies full of protein, and actually couldn't feed and couldn't do anything. Well, in fact, there are a subpopulation of those patients as well who end up getting organ transplants. So out of that, the most important message I can give you is that the risk of having major complications, such as the one probably most dreaded other than mortality, and that is getting this tumor formation from your lymphocytes that's related to infection from Epstein-Barr virus, only affected 1 in 20 patients. And again, of those patients, those are the patients who are most ill, who most had problems with rejection episodes, required repeated treatment of their rejection with high doses of immunosuppression, multiple doses of steroids in order to control rejection, and they got a response with a lymphoma resulting from all that. This is not usually the patients with liver-based metabolic disorders. And finally, I think that, I shouldn't say finally, but in addition, so there is a concern of growth rate effects related to transplantation. I think most of those are related to, number one, how sick the children were before they got transplanted. Many of them do have catch-up growth, but some of the problems that we've had with organ transplantation is related to use of steroids to control rejection. Well, we're not using steroids as much anymore, and I think that this data goes back almost 10 years. I think if you look at the data of more recent transplant programs, you'll see that the issues of growth retardation related to transplantation is significantly improved. And finally, the issues that probably the most important other issue related to the use of immunosuppression drugs is that people are very concerned about kidney function. So a GFR of greater than 90 would be considered to be acceptable kidney function. I shouldn't say acceptable. It could be considered relatively normal kidney function. And really considering, again, the broad spectrum of patients who end up getting organ transplantation, only 10% of patients have kidney function that's less than perfect. So that you really need to understand that while, yes, we're all afraid of the side effects of immunosuppression drugs, but they are not as severe as most people believe, and most of the time they're controllable if we recognize the consequences and we shift around some immunosuppression drugs. Yes, there are issues related to hypertension, people gaining weight, and everybody's got this problem, and also lipid abnormalities and higher risk for having coronary problems. I think some of that relates to diet and some of it relates to the medications, but now that we're aware of it, we have a better handle on it. So the main message I can give you here is that organ transplantation, and again, I'm not telling you that organ transplantation is the right thing, but I will tell you that if some of your most severe PKU patients actually were being followed by a hepatologist, there might very well be some of the hepatologists that recommend potentially an auxiliary liver transplant for PKU, because the alternative of taking the risk to have an auxiliary transplant, that is only having part of your liver removed and getting transplanted with a new liver, would potentially actually resolve the issues, get you off the diet, and then you could deal with the consequences if it's worth the risk. Again, if the consequences and the side effects of the immunosuppression and being followed by a bunch of surgeons and hepatologists didn't drive you crazy, you could make up your mind. And if it wasn't acceptable to you, then you could withdraw immunosuppression and have the graft either removed or just enveloped. I'm not saying that organ transplantation is the right answer. I'm simply saying that having the opportunity to speak to this group, I have an obligation to give you the idea that there are alternatives out there. So I'm not going to touch on any of these. You folks know these better than I do. As I said before, the vast majority of this is from my education, and it's been confirmed here by all these wonderful previous speakers who have really opened my eyes to the field, and it's really been a treat for me. And to give you some idea of how much of a treat it's been, even the first speaker on advocacy is somebody I can relate to, because I actually have a child with autism. And I've been down this road before, and I understand what the issues are. So let's get to the subject of cell transplantation, since I don't really need to talk to this audience about PKU. And so what is it we intend to do with transplanting liver cells? So the first thing you need to understand is we get liver cells from organs that are not used for transplantation. Now, it used to be that we didn't get them very often because over the last 10 years, the number of organs that are not used for transplantation has pretty much gone to zero. I mean, we use almost everything now. 10 years ago, when I first started doing liver cell transplants, it would not be that unusual to get an organ that would potentially otherwise been acceptable for organ transplantation. In fact, we used to argue with some of the organ procurement agencies saying, do you want to use this for an organ transplant? And they would say, no, we offered this around and nobody wants to use this organ. And so we would take the cells and we would transplant them. I think the one area where cell transplantation really opens the door away from organ transplantation is that there's one group of organ donors that really has not worked out well for the transplantation world that works out extremely well for cell transplanters, and that is the donor that is died from cardiac arrest rather than neurologic injury. So the cardiac arrest donors are patients that have low blood flow, have low blood pressure for a significant period of time, and those livers don't work because there are injuries to the bile ducts, the drainage system of bile from the liver, and also because the blood vessels have a higher risk of getting clotted after transplantation. But the liver cells are perfect. So that there is a much larger population of organ donors for cells for transplantation than anybody really appreciated a decade ago that may very well work to be useful for cell transplantation and for treating children with metabolic disorders. So this is an example that I give. It's sort of the best example I can give about what actually we've accomplished with cell transplantation in metabolic diseases. And this is a disease called Crigler-Najjar syndrome. Like PKU, it's a recessively inherited disorder. It's an absence of a single enzyme. There are multiple mutations that have multiple different effects on the phenotype, et cetera. And these folks routinely go for organ transplantation. Their risk is they have very high bilirubin levels. They are extremely jaundiced, and they have a different kind of jaundice than you see with your average drunk that's walking around who you think of as having liver disease, because they have what's called unconjugated bilirubin, and that unconjugated bilirubin crosses into the brain and causes brain injury. And if the bilirubin stays high, these kids have severe neurologic injury or they die. And that's why these folks are routinely referred for organ transplantation. The only therapy that they have is actually phototherapy. So you remember, all of you probably know someone who had a child who was jaundiced at birth, and they put him in the window, or they gave him phototherapy lights for a short period of time. This is it, but this goes on until you're 30 years old. So this is the only way to control bilirubin levels, and it's not that great. So the bilirubin level actually, once it gets in the area of about 25 milligrams per deciliter, which is, you can imagine, quite high, these folks start being at high risk for getting this thing called kernicterus, which is the brain injury problem. And that's when we start saying, listen, it's time to get you on a transplant list and get transplanted. So we got permission from the FDA to do a hepatocyte transplantation. We had a couple of candidates come through. And this first child we decided to treat was an 11-year-old kid who'd already had one episode of kernicterus. So they're on such a tightrope that this child was getting phototherapy of about 12 hours a day, and she got a strep throat. And once she got strep throat, that pushed her over the edge, and she actually had an episode of kernicterus. She had to be admitted to the hospital. She got plasmapheresis. She got high amounts of phototherapy, around-the-clock phototherapy. She got out of it, and she was a candidate for organ transplantation. She was on our list. Well, the family was very excited about the idea of having a cell transplant, because the idea of having to replace an entire liver just to replace an enzyme was just not okay with them. So we agreed to do this. The way it was done is we knew that we had cells. We brought the child in the hospital. We put her in the intensive care unit, and we did the same thing that you would do as if she had an episode of kernicterus. We put her on phototherapy, intensified phototherapy, for the period of time where we were waiting for the cells to get processed. We ran her with a lot of fluids to reduce her risk of getting kernicterus. And then we took her down to so there's no surgery. I shouldn't say there's no surgery. There's a surgery, but it's, you stick a needle in the side, and then you put a catheter in the liver into the portal vein, like that picture I showed. You'll see the picture again. And we put a catheter in the main blood vessel that supplies blood into the liver. And then we transferred her back into the intensive care unit, because I was scared to death that the period of time it would take to put all these cells in, and she was under no phototherapy, that she was going to get a high bilirubin level, and I wanted to actually do all this while she